She got it.
Okay, she heard me.
Good job.
Thank you. Okay, I apologize for the late start.
That's fine. Okay. So I call this meeting to order. Carrie, do we have a quorum?
Yes, Madam Chair, we have a quorum.
Okay. How about I lead in the pledge? Ben, are you up to full start?
Oh, absolutely.
I pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all.
Lord Jesus, we thank you for this time that we can gather and we can conduct this business. We ask that you be with us and give us wisdom, give us strength, give us courage. Help us all we do to glorify you and help us to be able to serve this community. In your name I pray, our Lord Jesus Christ. Amen.
Okay. Do we have any additions or changes to the agenda?
You guys need a agenda for the election?
We have one. I think we have one.
I think you talk about credentialing for VA.
Okay. Well, here in just a few. Oh, you got it. Okay. Here in just a few minutes, I'll give you the opportunity. Okay. Any additions or changes to the agenda?
Yes, we should make one. I don't see public comments on the agenda anymore.
Thank you.
It's
Visitor
way
comment.
down here.
Visitor.
Didn't we used to have it
Okay.
above
Yeah.
that?
Potentially, I think.
It's potentially, it's been above there before, yeah.
Okay.
It's-
Okay. I'm okay with it.
Okay. As long as it's on there,
Madam
Oh.
Chairman, I had sent you an email, but the executive session provisions aren't what I had put in the agenda I had sent. So they probably need updated when you get to that matter.
okay, thank you.
Yeah,
Allison.
we've got what you sent us.
We saw that.
Okay,
Thank you for
thank you.
noticing. Okay, the minutes.
Madam Chair, I have one change to the November 21st minutes. On page 3 under quality, it says AR days have increased. The goal is to have AR days at 242, which
that's
is not my goal. It's not mine either. I thought
That's
we said
43.
40. I think we said.
You said 43, you said
That's what
it,
I
yeah.
I thought it was 42 or 43. So if we could change those minutes.
Yes. That'd be pretty bad and we wouldn't even be able to sit here. So.
Have to run. Okay, is there any other changes to the minutes? Do I have a motion to approve those two sets of
Madam
minutes?
Chair, I so move.
I second.
All those in favor, say aye.
Aye.
All those opposed, same. Okay. Ben did. Okay, so now, do we have any visitor comments? You might go ahead and tell us
That's
your
me.
name.
My name is Jim Hurley, and I'm a veteran in the area here. And as you all know, there's a lot of veterans in this area. And we have to go over to Hot Springs or Fort Meade for care. And I understand that the VA has a credentialing program where the clinic could be credentialed with the VA. So you could go in here locally and get care, and that would be paid for by the VA. And the VA does come to town 3 times a month, I think it is now. But it's very hard to get an appointment. Before they got to 3 times, I was going over here as my local clinic. And it was 6 months after they didn't show up for appointment before I could get another appointment. So I transferred over to Hot Springs. If you're in Hot Springs, you can't come here. If you're here, you can't go to Hot Springs. You can go to an emergency, the walk-in clinic over there, but your provider is either here or there. So if you could get the clinic here credentialed, I think it would be a help to all the veterans in the area. The nearest credentialed clinic is in Custer. So I think it's that Monument Health facility over there is credentialed. And I don't know all the details of it or anything like that, but I just thought I'd come here tonight and put in the word to the board to look into that and move forward with it.
Thank you.
Thank you.
Yes.
Thank you very much for coming, and thank you very much for that suggestion. I didn't know that. Is the credentialing that you're talking about, is that different from the VA community care?
It's
Or
part,
is
I
it-
think it's under community care.
Okay, so if we could get credentialed for that part of it, that would take care of the need, you think? Or is it a totally
If we
different?
could get the clinic here credentialed, yeah, I think that would be a big help. You know, if you had the flu or something like that, bronchitis, whatever, you could go in here and get care, or if you needed to be sent someplace else, you had a professional to, you know, tell you what you need to do and who you need to see and so on and so forth. So they are very, community care in this area is very good, and they are very good at sending people out to community care. And this is evidently a way of spreading out access for the veterans that are not in, you know, large locations.
I think, Mr. Hurley, that's good information too. So I know that the physical therapy for the hospital is credentialed to be able to provide care.
Well, but
And so I know, I'm not sure how exactly it goes for the clinic.
you
It's
have
probably,
to, I'm going to peek you right now. And one of the interesting things, I guess you could say, is that Hot Springs in South Dakota is under United Healthcare Optimum Plan.
Mhm.
Wyoming and West is Tri-West. And so if I go over to a doctor over in Hot Springs or Rapid City, and they ordered me to take physical therapy, I said, well, I want to do it here. You have to have a new consult for here because of the billing.
Okay.
So to get the billing in the right pocket.
That's actually changing as of January 1.
Right.
We're all gonna be in the same district now, so you won't have to get that.
yeah, we just got notice of that. Yep.
Yeah. So that's a plus.
But does
That's a
that-
big plus.
Does that
So,
solve this
Does
problem or
that change
not?
whether it's been paid for by Tri-West or United Healthcare?
It's gonna, yeah, it changes it. It's gonna be called something like, it's gonna be called something like Tri-West West or something like that.
Yeah.
It's an interesting, it basically says these states are included in it, and Wyoming is in the one that says West, and yeah, so
But I think South Dakota is in different.
I don't remember because I
Well, they're
just read it.
changing they added more states to the west.
Mm-hmm.
So, yeah, but you're right, it doesn't take care of this
Well,
problem. It just makes your referral problem a little easier.
Yeah.
Well, the nice thing about it here is that you can get a consult quickly.
Mhm.
I moved here from the Seattle area, and the last time I went in for a consult, they told me it'd be 6 months to a year. And that doesn't happen here.
No, I was just asking about like if it falls under community care, because I know community care, you have to get a referral.
Yeah.
So if we didn't fall under community care and we were just a provider, then you wouldn't have to get referrals. to
No,
come
you
here.
can go into the clinic here and get taken.
That's the difference is rather than having to go through community care first, they could just, the veterans. could
I'd
just walk
rather
in.
have them where they
Yeah,
could just walk
walk
in.
in.
Yeah, that's
So-
the reason why I was asking
So, so Mr. Hurley, I think we'll have to do our homework, but I'd like to get you an answer when we can figure out what we can do or not do. Would you feel comfortable sharing your contact information so we know? Oh, you got it? Okay, so JP.
Best HR guy I ever met.
to. We like him too.
I tell the joke.
Oh, yeah.
I worked for Pacific Telephone for 33 years out in California. I had a VP, which I was in marketing my last several years. And he said, if you're ever locked up in a room with an HR guy and an alligator And you got a revolver with one round in it, shoot the HR police.
Harsh.
Wow.
But he's been over to the senior center and at coffee time and whatnot, and talked with people and visited and whatnot. I think he's a great representative for the hospital.
We think so too. Thank you.
I
And
guess
thank
he'll
you
be on
for
my
him.
way.
Okay.
Thank you very
My
much.
husband is a veteran, so thank you for your service.
Madam
Yes.
Terry Jones, thank you for coming.
Thank you.
Yeah. And thanks for bringing that to our attention. Yeah.
Glad to do it.
Okay.
And while I'm here, I might as well pitch my computer clinic on Monday afternoon at the senior center.
Okay.
We're open, anybody comes in. I don't know how many of you are aware of it.
My father-in-law comes regularly.
Yeah.
Very good.
Yes, thank
I'm
you.
very appreciative to you, because otherwise he brings his computer over to me.
I had a brother-in-law that was in South Dakota when I was living in Laramie, and he used to call me, and he'd have 30 or 40 Internet Explorer pages open,
Yeah,
and they'd have to shut this down, shut this down, shut this down.
Can't do that.
wonderful. Wow, it does slow things down.
Okay, well, I think we are on to the strategic initiative, so usually there's no other visitor comments. Yeah, oh yeah. Any more?
Is there any more visitors on the, that needs to be?
Nice man.
Okay.
Okay. So Kathy and Tish, I think.
Yes, Tish,
you wanna
mhm.
Go, sure. Start with, go for the finances.
Absolutely. So I apologize. I'm gonna send everybody an email notification as to where I hide the financial reports.
We'll get it figured out.
Yeah, it doesn't do any good to send them and set them out if nobody knows where they're at. So we are still working on prepping for our 2024 audit. We have some roadblocks to do that. One of the things is we have to get the historical data out of Meditech. That hasn't changed. We are still shooting for mid-January. They did say it could take up to 6 months, and I said, no, I have a quote for you for 30 days. So that's what we're going to hold them accountable for. When we get that data inputted, then we'll be able to confirm all of our reconciliations and things like that and be able to start prepping reports for the auditor. We did file our initial Medicare cost report on time.
Can I interrupt back there on that? So who is, so is that Heffley still, or who's doing that?
Whiffley.
Sage
Whiffley.
And they're the
So-
ones that's doing this Sage.
Yes,
Meditech.
and so what I did was I put them in touch with the Meditech transition team so they can work out specifications and things like that. Scott from Meditech indicated that once the specifications were set, it wouldn't take long to get that data over, because you're looking at data from July 1st of 2023 to January of 2024, plus all of the 2023 data. So it sounded like a lot of data to me, but they assured me that it was something that could be done relatively easily once the specifications were done. So,
And we want to be done by, we want to
I'd
be
like it
done
done
by,
as soon
so
as
that we can
possible.
get out of our Meditech
Just a quick
contract in
question.
February.
What's the date range of the historical data that will be moved from Meditech?
all of fiscal year 2023, so that's July 1st of 2022 to June 30th of 2023, July 2023 to January 2024.
But nothing before.
All of that, no, we don't need any of that.
It'll still be stored.
It's stored there, but we don't need it to be active in our current date.
We'll have it stored.
We're gonna download it and keep it, we can hold it on a server,
Oh, okay.
and then we can access that server, or Wendy can access that server as needed. But,
Gotcha.
so,
We don't want to need it. That's kind of old data. Just
It's,
hope to not need it.
Right.
yeah,
But you never know, so
You never.
I just wanted to make sure we were gonna
yeah.
keep it.
And we'll keep it, we're also gonna keep it in downloaded reports.
In addition to the weekly printed version of the newsletter journal, we also promote our community and share important information on our award-winning website, newslj.com, and in our weekly email newsletter, Nuke Now. We also connect with readers through various social media platforms and invite you to check us out on Facebook, Twitter, and Instagram. You can even take a look at a recent meeting of the City Council, School Board, or County Commission on our YouTube channel. We do hope that you will go to newslj.com and subscribe today, and we look forward to making all of our great content available to you. But regardless of your level of support, we thank you from the bottom of our hearts for doing your part to preserve a free and independent local press.
And we'll keep it, we're also gonna keep it in downloaded reports. That's how we'll keep it, in downloaded reports. So we'll do the detailed trial balance, the summary reports, and all of the historical documentation to make up those reports will go into storage. Okay.
Sorry for the interruption.
No, that's fine. It seemed like a lot of data to me. However, I guess it's really not when you deal with millions of gigabytes on things. So once the audit has started and completed for 2024, we'll be able to finalize and file for a 2024 cost report. I anticipate, based on the interim one that we did file, because our clinic rates went up, we're going to have, we're going to get some money, and we're going to continue to put that into a reserve account where we can't touch it, because chances are when we file our final report, we'll have a payable, because it just flows back and forth about every other year. So we just want to make sure that money is available for if there is any responsibility for the facility to pay back CMS.
And is that going to be a different account than the money market account?
Yes, it will be a different account for the money market account. And it will be very restricted. So, and there will be no transfers without duplicate signatures, and we'll set it up so it's very secure, and we can't just arbitrarily go in and fix things.
And is that going to be a new account that we don't have now, or just use one
If
that
we know yet.
I'm
Do we
not
know?
sure yet.
We have a lot of accounts, so
We have too many accounts, but that's a discussion for next finance. So, you're welcome. The charge master, or the data charge master increase, so I was able to send our data charge master with usage to Ready Health today, and they anticipate that it will probably take them 6 to 8 weeks to complete their analysis. They'll let us know if because they'll send it to us for final approval. One of the things they're going to do is they're going to compare us to all like hospitals. We're going to see what market share we can capture, and charges may go up or down depending on the share, the market, what the market will bear. So I think the last time they've done something like that was 3 years ago. Or was it 4 years ago? Okay, I was looking in the files, and there's one in there, but I didn't know if it was something that had been adjusted or not. Cash flow continues to be well. So that's always a bonus. So the delinquency on our price transparency on our website has been rectified, and we haven't heard anything from CMS. They will go in, take a look, see if it meets their standards. They'll never tell us if it meets their standards. They'll just tell us if it doesn't. So no news is good news as far as I'm concerned. And we did have a new 2025 requirement that says we need to put all the payer, so those are like Blue Cross and anybody who's a payer, their modifier requirements have to be posted as well. And that's a 2025 CMS requirement. So we're already compliant with that. We went ahead and did that while we had it. We are getting a bunch of managed care contracts from our payers to start looking at, to have them become viable payers here. So they don't have any, like Blue Cross Blue Shield has a new managed Medicare for Wyoming. They haven't launched it yet. So they're kind of doing the equivalent of a survey. So they send them all out to the hospitals. We read them. We look and review at our fee schedules and things like that. And then we agree to take them. What we don't know in advance is how many members we're actually going to have in the area.
Well, and the other problem is they're offering us quite a good rate, but I don't think that'll last. That's the honest truth. And I think that the reason they haven't started is because they haven't gotten people signed on yet.
Right, from hardly
Other
anybody.
hospitals.
Yeah.
And clinics.
They have to build a provider network,
Mm-hmm.
yeah, to
Yeah.
prove
And
that
I
they
don't-
can do it.
Yep.
So,
And,
so what's the incentive to sign them up?
It allows seniors in our area to get that kind of coverage, if that's what they're looking for. I'll give you an example. Where my address is in Idaho has no managed care contracts, don't cover that zip code. So I can't get a managed care policy. So that's what it does for the community members. that are
It's
here.
like sometimes you can have vision and dental and a wellness visit that's free and things like that. And then usually the managed care also do a quality piece. So they want us to report back on our quality metrics, and you can get incentivized for doing, above standard care or at standard care and that sort of thing. But where people are saying no to them, and it's going clear across the country, it's because they really don't pay well, and they're not paying to the level of requirements that they're asking for data relative to quality and that. So it just depends on your philosophy. Do you want to be part of that and then have, it's not bad to have the quality metrics to be able to look at and stuff, but it's whether or not they're going to reimburse you to the place that you can afford to sign them on as a.
Is this a similar thing as to what, can't remember the other name?
Advantage?
Yeah, the Advantage.
Yeah.
It is.
So which
it is.
It is.
has-
What
Which isn't
they-
helpful, right?
Right.
The
Yeah.
Blue Cross brings to the hospital is they tell you they're gonna bring you more patients, but to Kathy's point, if they haven't built their network yet, that you don't know how many, if they bring you one patient or 500.
Right.
So
So
they
will,
may bring nothing.
I assume that a detailed analysis would be performed. So if we, and I hope I'm not treading into operations, but I'm just for my own curiosity. If we signed up with them and it worked for a while, and then they start paying us less or something like that, would we be able to detect that change?
Oh, yes. you
Oh,
can
yeah.
right away.
And would we be able to,
Cancel our contract.
You can
Cancel
cancel
or
the contract. There is a cancellation clause in there. What is not included right now is the fee schedule.
Oh,
Right.
well, that's kind of important.
so you don't?
Yeah, it's not included. There's promises. On the phone, they promised John and I some good rates, but it wasn't in the documents. And then the second part of it is that I think they were really hoping we would sign up, because then that way they could start to try to get people. Because one of the challenges that you have is we're going to try to figure out how many Medicare patients in this area will take Medicare Advantage. I mean, we could try to do a survey, but that's Blue Cross Blue Shield's job to try to figure out how many people they can get signed up. So us doing a detailed thing really has more to do with, are they going to pay us enough compared to our pricing? That's what
Yeah.
that's what I think it's really boils down to.
What's our percentage of bill charges that they're gonna pay? And so I reached back out to the lady because she followed up. She goes, "Oh, are you guys ready to sign?" And I go, "I need the fee schedule before we can do anything."
Yeah,
She said, "Oh, we don't have that yet." And I says, "Well, get back to me when you got it. We'll
Okay. I
we'll
got
take a look depending on what do they pay for a clinic visit, what do they pay for an ED visit, inpatient."
she's a smooth operator. I will tell you that. She's
Yeah.
very nice, smooth operator.
Very, very nice lady. Yep, she's very nice. So,
So proceed with caution.
always, anytime you sign, because it's so much harder to get out than it is to get in. So, the GL mapping is complete. We had, a payroll today, so I'm gonna go in and once it hits the general ledger, make sure that it's hitting correctly. And then we can go back in and make all the corrections. So we did hear from Sage, and it is not in their contract to go in and remove all of those payrolls. So we'll need to remove all of those payrolls manually. There's 17 payrolls that need to be reversed. And you have to reverse the whole thing because you're going to retransmit the whole thing. So I went in and started fixing the journal entries. I opened up a ticket with Sage to see if they would allow an upload because the payroll journals are 50 pages long. And so reversing them is a little labor intensive. So
Is there just a one-way street between ADP and Sage? Is there any
yeah,
chance?
they can't go back.
No chance.
No, they can't. No, that was why I reached out to Sage in the first place. So that's kind of a continuing saga, but at least we got the information to hit the general ledger correctly now. So then we need to go back and retransmit those. I just didn't want to clog up the general ledger until I absolutely had to. So things are working slowly but surely. We did complete all of the Epic transmission errors. So those are all completed. We continue to see an occasional one, but it's easy. We fixed the GL mapping. So there were 205 errors. So what was happening was we were posting into Epic. Epic then in turn pushes it back into Sage. So that's the path. Anything that had the wrong general ledger number or the wrong department didn't go over. It just kind of went into no man's land. So until those were done, we didn't have all the data to do the bank reconciliations because we're looking and say, okay, it's here, but it's not here. And how does it get here? So that's kind of what clued it and got it started. But for the most part, I did complete all of the 205 transmissions, fixed the GL mapping, and then periodically we're just seeing a blip, but we've had one in the month of December. So it's a big improvement. Yep. So that's a big check mark off of my list. So accounts payable, we're continuing to fine tune the process. So we are running testers right now through Adobe. So what we're doing is we're scanning the invoices in and we're sending them out to the department managers and they go through. So then they can sign them in Adobe and then they come back. And then we can just upload right from there directly into the accounts payable module. So we have that backup that the department manager has approved it. One of the things that we found was that we were sending things out without recording them in the system. So we're missing things. Department managers, it's not their forte to get all that stuff and look at it and return it timely. So this kind of, we at least have it in the accounts payable module. So we can send out a reminder, hey, we sent this to you on such and such a date. Could you review it where it's up for pay? We'd like to include it in the paycheck.
We have
So
a timeline turnaround that you're looking for to get that process done.
48 hours. We're making a lot of phone calls and most of them are like, oh yeah, no problem. So we just did a few before we send it out live. So I'm hoping that we can send it out live throughout the facility by January. So I'm taking that as it's pretty much done. The inventory, so I didn't know when I first got here that the inventory module in Sage had never gone live. So when you look at those numbers, I couldn't figure out what was wrong with them. So what that means is all of the inventory or the supplies are recorded into inventory because that part works. But the part that takes the requisition to the department doesn't work. It's never gone live. What goes from the floor to the patient isn't happening. So we haven't billed any patients for any supplies since January
Of which,
this year, 2024. So we're only talking
Only a
this
year
year.
behind.
Only a year behind, yeah. So
I'm not so sure that it's longer than that, but
whenever they went,
when they went with
January.
Sage, they really had a department that was disconnected. Yeah.
Dollars does that equate out to?
well, we had 6 million in supplies expense on our audit. That may include pharmaceuticals, I'm not sure.
It
But-
does.
So it's supposed to be about 13% of our spend, on average for most hospitals. So that'd be like at least 1.3 or close to 2 million. It's a sizable amount. It's
It's
not
a chunk.
I want to,
insignificant.
I don't know if it's actually 13% because that was an AHA quote that you had. And so that's for all different size hospitals. So we'd have to really look at what ours for a critical access hospital would be, but
But it's a lot.
it's a lot.
It's in the millions for sure.
I think we're overstock.com or something like that right now, so.
The new store. This is the one-stop shop. We have a pharmacy. We have a bootlegger's liquor. The deli, the food that you can get at a lunchtime is so amazing. The coffee shop. Certain Friday mornings, there's 30 people sitting here in all these chairs. This is the hub for people to come and visit, have their coffee, have their donuts. It's amazing what this area has done. Totally amazing.
It's in the millions for sure.
I think we're overstock.com or something like that right now, so.
Yes, so, yeah.
And so is there any way to recoup some of this since January?
Not really.
No.
There's probably no way to go back and rebuild people.
Right.
Well, the
And
thing
we
is, you
don't
have
have
to
any-
bill the insurance. Most of the insurance companies have a 45-day block with the exception of Medicare and Medicaid. Medicaid pays you less every month. They reduce your payment amount. The part that would be hard to manage is at what point we'd have to go into all the payers' accounts and put ourselves as the secondary or the tertiary insurance so that the patient wouldn't get a bill. Because
If we
otherwise we're
could
gonna have
even if we could
patients.
have it, we'd have to go through all the documents to
Every
look at
single
what they
one.
did, to see what kind,
Right.
and then you'd hope that they wrote down what kind of dressing they used, but they may not have.
Probably
Right,
did.
yeah.
So
Right.
Are supplies kept in Pyxis so that when nurses get stuff, they punch a button that they got?
They do, but it doesn't, but Pyxis isn't attached, I mean, Omnicell, we don't have Pyxis.
Yeah,
Omnicell isn't attached to our charges, so, other than from the medication side. So basically, our whole supply department cost us a lot of money. Yeah,
So we've eaten all the supply costs basically.
and it hasn't probably showed up on our cost report.
We haven't filed the cost report, correct? I
But
mean, we haven't
the
done
corrected one,
the
yes.
corrected
So it's a
one
huge
yet.
area for improvement.
I gotta
It
ask the
is,
question
for
then.
sure.
I'm sorry, I have to ask the question. Whose responsibility and where did that fall down? That didn't ever get connected?
Well, I was gonna talk about this in executive session because it's employee related, so,
Yeah. So
yeah.
we've identified it. We have a plan in place. That's,
We aren't going to tolerate any of that any more.
Because that's a huge
Yeah.
loss. I mean, that's.
It is.
But I don't think there's really any way to recover it. But will the Omnicells ever talk with our GL to attach the supply usage?
I
to the
have to
patient's
check with
account?
them. I haven't gotten that
Probably don't have-
specifications
We probably
back
haven't
yet.
paid for an interface with it, is
Probably
my
an
guess.
interface.
Finding a contract around here that's current and that you can read, is challenging. I'm not, that's not an understatement. I spent hours and we finally had to go back to well, I didn't, you did too, but we spent hours just trying to find the documentation of when we became a hospital district.
I thought you said when medications are taken from Omnicell, that those are being tracked to the patient's chart,
They should be.
and then
yes.
that
And
talks
that's
to our
through.
billing system.
It's supposed to.
So I think there's another thing called M1. This is the stuff we're trying to learn. So there's another system called M1 that has something to do with an interface with Omnicell so that we do get the charges moved over to Sage. So why we have that many systems to get them to, instead of just a direct interface, I got no clue.
So
But-
the place I'm going to, the question I really want to ask is, since it doesn't really work, is Sage the best solution for us? Or are we gonna be open-minded when we look at this and say, we need something that works, nothing works? We could use Sage. Is there something better?
So there's always standalone inventory systems that work with Sage. I've implemented several. To say that Sage doesn't work is a little bit
Well,
misleading.
I'm sorry, we've never used it.
And
that-
it was never set up correctly.
Right.
Yeah,
but
let me go back and say,
Sage is
since we've
supposed
never
to-
really used it.
Sage
But-
is supposed to be a leader in that area, which is part of the reason.
And do you
why
They have
think
a
that's
great
why?
flow.
So
Okay.
they just.
Yeah,
haven't
I
made it work.
think the thing to be said is that you have to have people, well, here's what I'll tell you. We had Wendy sign up to be the lead to get this done, and she's not gonna put up with anything from the people, and we will carry it out as far as we need to go. But we're paying $7,000 if we get approved, which please do, $7,000 to redo something that should have been done the first time around. So basically getting that interface done.
That's what it's gonna cost us essentially,
Yeah,
to get it working properly so that we're, okay, well, it'll be worth it
but
probably.
but otherwise, if we go to another system, right now, I would not offer to do that because we just don't have the capital.
I just wanted to make sure that since I'm happy to pursue this, but when we fully pursued it, is it going to do everything we need it to do so we can bill accurately for all the supplies, we can see the usage, and we can make sure it gets on the cost?
So the patient's part goes into the EMR, which is Epic. What's going into Sage is simply the accounting piece. So, but they're not talking to each other because they're not live.
Right. And so for our budget purposes,
Mhm.
which we're hopefully driving towards, supplies by department, some departments use more than others,
Oh, yes.
will be a very relevant budget item.
So this is part of that, it's that same problem of why we can't get the supplies into their respective departments.
So I just want to make
Those have to
sure
be
that,
done manually as well now.
that you're thoroughly
But they
convinced
will
that
not be once the.
that
Correct.
this
Yeah,
system.
I have
will
to go back
all that
and
we
do
need
journal
for
entries.
our Budget, billing,
I'm-
and if everybody's convinced, then
I'm thoroughly convinced that the people that work down there don't know squat about what could be done because they didn't want to do it. So now we're going to change that. So the question about the charges, it should be that the charge master is in Epic, and as long as people document that they've got those supplies and stuff, then it should charge across. But it has to also be in Sage for the accounting part of it. And so, yeah, but the rest of it, I really don't want to talk out in the public about.
So, also the state of Wyoming, sent me a nice little letter and said that we needed to submit our budget, and they were kind enough to send me the form. And, that's been completed. The 2025 budget has been completed, and I'm waiting for, Alicia to send me the 2024 spreadsheet. And so, and then we'll be able to input that as well.
Why can't we do the 2024?
Not to the state of Wyoming.
To the state.
To the
We
state,
talked about it.
we've talked about so many things. We did send it to them, but we didn't put it on the form.
Right.
It's got to be their
It was
form.
a form that I had no idea about, and so we had to put it on a form.
Yes. That's,
Yes.
I remember that happening right when you got
Mhm.
here, that first month.
Yes, right.
They don't like anybody else.
No, they didn't. And I sent it to her twice with the same thing, saying, I've sent you the budget now. And she said, she finally emailed me back and said, it's got to be on our form.
Yeah.
Oh.
That's a typical
right.
answer from the
Okay.
state, but yeah.
All right, great. So, that's 2024 is still pending. And as soon as I get the form, I'll be able to just go ahead and upload that since I got the 2025 in. I wrote myself notes and sheets. So we have started on our chart of accounts reconstruction. So I've done the chart of accounts and it is now in a CAW format. I'm sending it off so we can make sure that all the underlying reports feed correctly with it. So it will go into effect immediately and everything will be that way for our 2024 audit going forward. So, and the auditors just said as long as I created the crosswalk, they were fine with that. It wasn't going to cause any problem with them. The 25 budget, I do not have an electronic version, so I have to create an electronic version so we can upload it into Sage. So then it will be on all the financial reports.
Do you guys have any, do any of you have the electronic budget?
Just a paper
Well,
one?
Because you guys,
Durban
Yeah, but
made
Durban
it
did,
for us.
right,
so they
Durban
have
did
to-
it, why can't they send you a?
I
electronic
Didn't know
version?
they
Yeah,
done
they
it.
did.
We
Okay,
paid them to
We did.
that's what
update
I
the
wanted to
budget.
know. Okay.
Durban did it.
Durban did it.
I'll reach out to Greg tomorrow and have him
Yeah, there should be no reason why.
They
do
have
some
electronic.
scrounging it. Yeah, because it's,
Okay.
I promise you they didn't do it with typewriter.
Agreed.
yeah, because it's on paper and I'm like,
Right.
so let me call Greg and get that done. That will be great. And then as soon as we get all of the other little things taken care of, I anticipate being able to do financials. So I'm looking at an additional 30 days. So December isn't going to cut it. Maybe we'll be able to get something by the end of January, provided all the stars align and everything gets done. So that's kind of where I'm going. So on accounts receivable, our days went up by 1.1 increase over the prior month. I did, if you want to go to page, it's page 4, looks like this.
Self-pay.
Self-pay. So you can go through and look at your leisure and let me know if you have any other questions on any of the other statistical report. I just wanted to show that the self-pay service credits went up by almost 10,000. So I thought, well, I wonder why from the prior month. So I went in and did a breakdown of which is typed down at the bottom. So we found that there were 117 self-pay accounts that had credit balances. It didn't necessarily mean that the patients overpaid. Some of them are posting errors, some of them are contractual errors. So we're working to get those all cleaned up and to only have what's in there remaining be true self-pay refunds, which we refund every 30 days. We have $18,000 worth of professional billing credits as well. A couple I looked at looked like posting errors, but I didn't dig down a whole lot. And then we have 178 accounts, miscellaneous accounts that could be lab, family practice, MRI, CTs. They'd either have mispostings, wrong contractuals, or credits, bona fide credits, in which case we will be refunding the insurance if that's what caused the credit, or the patient if that's what kicked over for that credit. But the majority of them are posting errors and not true bona fide credits. So we don't really owe that 50,000 to anybody, which was not a lot of it. Yeah, not as much of it, I should say. So we went ahead and then we looked at all the statistics. So October is kind of an anomaly. So when you look at the statistics, kind of keep that in mind. So if you look from September to November, they're more in line. October was kind of, from September to October was kind of an anomaly because things bumped up a lot. And then they're going back down again for November. So you can look at those. Some of the statistics, like lab statistics, we don't have anything like back past October. So you'll only see that going forward. I'm not sure why. I wasn't here.
They didn't know how to get access to the reports. We had to get them a bunch of access.
Okay, so that's permissions issues as to why they couldn't get those out. And then what we did was, if you look at our cash flow, you can see that our cash increased with the exception of the nursing home. We went over that. The IGT is the 640,000 is IGT funds, along with the 204 that is pure from October, pure IGT funds. We haven't taken any money out of our money market account in 3 months. So we've been able to pay our bills, including payroll, benefits, taxes, on the funds that we bring in. And you can see that we actually had an increase in funds left over of 204. The salary and benefits are still not a viable number because I haven't completed the payroll corrections. So the benefits are still showing up as
Once you have
credits.
those 17 months or 17
Payrolls done,
then
yeah.
those will be
These will all be updated. Because it's been going on since whenever they did implemented Sage and
January.
HP was at January.
Mhm.
So we can go back, and then I thought we would also do graphs so we can have things more at a glance. I'm a big at a glance person. So our Medicaid rates went up. So those will at least stay up for the next year before we file our next cost report.
Oh, $260.
No, but the clinic ones went way up.
Oh, that's
Way
good.
up, yeah. They're over $350. Yeah, so they won't adjust that.
For a clinic visit?
Yeah, that's what I said. My eyes got real big and went, wow, that's great. It won't last.
No, it's probably because we had lower volumes.
Right.
No, it's probably because we had lower volumes,
Right, and
So-
it's based on the final cost report.
which is why we're
So they'll
holding
adjust
money.
it, yeah. So, again, I'm really conservative about stashing money away, so we will stash as much. Does anybody have any questions? If you find after you reviewed, you can always email me the question and I'll get back to you.
Finance committee report.
Yeah, so in finance committee, we discussed a lot of different ideas and, we thought rather than trying to be all over the place, that we should focus on a couple of key areas. And so we decided that we would focus on the nursing home and the clinics for now to, determine the profitability of both and what could be done to get a handle on those costs and turning those in a profitable direction, building volume and working on the costs in those areas. So that's what we're going to focus on for the next month. Did that cover it? Yeah.
Yeah, but right, that's our stated goal. And,
To really dig into those two areas. Maybe 2 months.
Thank you.
right.
Yeah.
Yeah,
Maybe 2 or
yeah.
3 months goal.
Yeah.
So how does that?
So there, we had discussed some different ideas in our last board meeting about how we could be better service to the public and identify the needs of the public and how to fill those best. So I think Shane's going to talk about the nursing home and a few of the areas that he has information campaigns. And then we will, as a board, talk about different things with the clinic on how we can let people know what's available. Our new providers, kind of highlight them and start working on a culture change within the clinic, as well as getting information out, but working on a culture of good customer service over in the clinic, so that I guess our bottom line goal is when a patient calls, we find a way to meet that need. Whatever the patient's need is, that's the priority, not our schedule or anything else in the clinic. The priority is the patient and their needs and how we can meet that. So
I'm sure you're gonna be focusing a lot on how much those doctors are seeing in the day, how much productivity they're having, how much expense related to it, all that's gonna grow.
So we've made great strides in that. We filled the clinic providers now. Kathy and her team have done a great job of making sure that there's doctors there for the patients when they call. Now we just have to figure out how we can use the resources that we have in the best way possible. And then really trying to hone in on what the needs of the community are and how we can do a better job of filling those.
And this goes kind of back to what Mr. Hurley was talking about. I mean, that really.
That's a
if we could
great,
get that certificate
yeah.
credential.
That is exactly that. When he was talking, a lot of lights were blinking in my brain. That's clearly a community need, and this community always supports our veterans. So that would be another great way
I
that
can't
we can
emphasize
serve them.
how much difficulty it is when you have something acute that comes up,
Yeah.
and your options are to call and try to get a referral or.
Yeah, I'm so glad he came because I didn't know that.
I
didn't know that.
Well, I didn't know it either. And we have the VA visits here, so
Yeah.
I just didn't know that. So,
It's the same because my husband has to go to Fort Meade every time he wants care, or we have to private pay whatever here so far. So that would be huge. Amazing for him to be able to be so right.
Yes.
And it would be, that's our goal. We're a community hospital. Our stated purpose is to fill the needs of the community. So it helps when we can identify those.
Yeah, that would be great if that works out.
One other need that's, I think, been identified and we probably all recognize is we are not effectively communicating with our community about, who's in the clinic and what can we do for you, and we've got open spots in the manor, and so I know we can't do anything about that right now, but that is a pressing need that is holding us back in lots of different areas. And so looking for a solution as to how we can begin effectively communicating with our community is going to be very, very important from a strategic standpoint, all that we do going forward.
And that's part of it.
Right.
That's part of the role of this board, of all of us, is to tell the community what we have and get that message out there. So, how can we do that effectively as well?
Is the Upton Clinic open 4 days a week?
mm-hmm.
It is.
Yes, it is.
Are people coming?
Yeah, people are coming in. Yeah. There's people that specifically like certain providers and stuff too. So it'll be interesting to look at how we decide to manage that clinic. Because I'm just thinking about whether it should be this person this day, this person this day, this person, or it should be one person, or what all the time would make better sense. And the only thing is that sometimes you get the same thing, female, male, and people being comfortable with one or the other. Sometimes it's preferences. So I don't have that answer yet, but we are trying to. It would be nice to get to 5 days a week, but I'm happy to make sure we're doing the 4 that everybody's used to so far.
So it looks like it's down from last year at this time, but it is moving up.
It's moving up since we started coming back there, and since we've been to the senior center over in Upton, and we've talked to people that will talk to us and stuff. So, but marketing's on an agenda for later too. So today
We did talk a lot in finance committee about how we, as a board, Kathy's doing great work, but she can't do it all by herself, and what we could do to help further her agenda as she sets it. So that was a lot of the discussion in finance committee, how we could focus and help her.
Yeah, I mean, I think it's our responsibility to kind of work with her, you know, yeah.
And not put too many pressures on her and her team, all of you.
So I had a question for the board. Would it be helpful for either Carrie or myself after our finance committee meetings just to type up a little summary on kind of the high points of what we discussed or what we're working on? Because I know quality committee does things. And I just wondered if anybody is curious to know.
I mean, like before we come here where you give the report? Yeah.
I mean, the beauty of the way the calendar is set up is that it's only 2 days, so my brain has still retained some of the information that we discussed.
And I know you've taken notes, and I've taken notes, so that if something would happen to get missed, we'll mention it. But as far as minutes or a meeting summary, that's up to everybody else. But I think what is happening in finance committee is getting relayed to the rest of the board. And we're looking for the board's thoughts on advertising or marketing, however you want to put that. We discussed a lot of different things. Well, we got people that worry about Dr. Ramuley. Well, we need maybe an article in the paper every week highlighting another doctor at the, these are my words. Every week in the paper highlighting over and over different doctors and do that rotation so that everybody knows there's a clinic full of doctors over there. And everybody knows there's room in the manor. And it can't be just a one-time deal. It's got to be repetitive over and over.
We figured
And
like 7 or 8 times before you remember something.
Yeah, that's
And
right.
I think, based on when we were doing the mill levy discussion, we need to do it in both papers. We need to do it on Facebook and we need to do it on the radio.
Mhm.
That seems
And
to
the
be.
same message each week.
Yes,
on all
yes.
Of the above.
Mhm,
And then the next
agreed.
week, the
So you
same
can
message.
have one ad or one whatever. Yeah, same thing. Yep, for sure.
At the same time, tout our talent here, the staff. We got to peddle ourselves to the community. We're at that position to peddle ourselves and got to promote that. And the only way they know that clinic's got doctors in there, male and female doctors, your preference. If we keep telling them.
Kathy we're working on all of that as we speak. It should be rolled out for the next 7 days.
And
I don't know if all of it's gonna be out within the next 7 days. Yeah,
We need to start with.
yeah, yeah. Yeah,
Right.
yeah, thank you.
Are we gonna get more specifics of that?
Later.
Okay. Sounds good.
Listen to the radio.
I prefer other methods myself, but.
So Nathan, do we want to talk about, and I've got a loss for word, your email that you sent out?
oh, right. Yeah,
This would be the time, I think, to talk about that.
So Carrie and I talked about that earlier today. And I think
Did
it
you guys all saw
probably
the email?
makes
doesn't it?
sense.
The older email, I didn't.
Yeah, it's older.
Yeah.
Was it within a week or
It
so?
was
I
probably
think.
a week or
Yeah.
so.
I think it probably makes sense to approach that through finance committee
Okay.
and then report back unless you had a change of
Yeah,
heart.
no, I mean, Nathan, the email that Nathan came out with is I called him immediately and I said, this doesn't even, it's too important and you put too much work into it to just hit reply. So I called him and I said, he's done a great job of analyzing and helping us to focus. And I told him that, we definitely, it's not something that we can discuss on the fly. We really need to dig into it, but it's a lot of great information that will help us focus.
Okay, so are we ready to move, anything else? Finance committee wise, are we ready to move on to the CEO report?
Quality, we can do quality first, because it's pretty short and sweet.
Quality's easy, we didn't meet.
Oh.
And you stayed here for all that?
Well, I
Well,
have
she has
this.
this.
Oh, all right.
Yeah, if I didn't get fully accurate.
Uh-uh.
Do you want me to just continue?
Yeah, go ahead.
So credentialing, you got Patrick Gleason for reappointment, Dr. Heather Peck, and then Dr. Tim Goebel. They're both pathologists at, they're both reappointments. They've been credentialed here for years. They do a lot of our consulting, working with our path reports, so, they're there for you to take a look at an executive. And then med staff, we had a couple of visitors come chat with the providers. One of them was Rehab Solutions here in town. It's the other physical therapy company that's in with Ashley Tupper. They're right next to Ashley Tupper. They just came and talked to the providers and wanted them to let them know what they can offer here in town. It's pretty similar to what we can offer. And then public health was here. So Angie Phillips and then Michelle Sweet were here, just kind of discussing what public health can do for the people in our community. They can do Depo-Provera birth control injections. She says it starts at $50, but if patients can afford it, it's just whatever they can pay. They can do STI testing, which is HIV, Hep C, chlamydia for $20, or again, whatever the patient can pay. And then strep testing as well for $40, or again, whatever they can pay. She said if it's positive, they send the results off to the PCP or their CHO, which is like your medical director who can write a script for them and treat them. And then they wanted to highlight that Michelle has over 20 years of lactation consulting experience, so she can do mother-baby services, education. If babies are having trouble with weight gain, she can go and help educate and help with that baby gaining weight. For pharmacy, our teleneurology group was here, and they wanted to know why we weren't using tenecteplase instead of alteplase, which is if you're having a stroke, those are the medications that you use to bust up those clots. So Suzanne talked about it with the providers, and they decided to move forward with the tenecteplase just because it's easier to administer all around. So then Suzanne said that going with that, Monument Health already has order sets and a protocol built in Epic, so there isn't any build that needs to be done. It's already in there for easy access for them. There's a medication called droperidol, which can be used for nausea or as an anti-psych med.
I always remember hearing people complain more about the federal government before, but that was when I didn't know about city and county government before I started working at the paper. Maybe it was happening then, but I feel like people have taken off their blinders a little bit and have realized that your local governments impact you on a daily basis, and those people have to be held accountable as well.
No, Alexis, you sound like me after 10 years of doing this. And I mean, I'm even here, we're hearing it from Walter, right? He has to go to these meetings and hear people talking out of both sides of their mouths. What's frustrating is that we've been saying for years, hey folks, pay attention. Everything you're mad at in Washington, D.C., people are doing in your local government in Weston County. Everything you're angry about in Cheyenne, whether it's waste, corruption, cowardice, inefficiency, guess what? It is all going on in Weston County.
There's a medication called droperidol, which can be used for nausea or as an anti-psych med. We were using it on one patient, which is on back order now. She's not expecting it to be back until around Christmas time. Pen-Vk, which is penicillin. She was surprised that that was on a back order because it's an old medicine. She doesn't know when that'll be back in. And then doing up, she was having some issues with, and she said she won't get any more of that in January. Keisha stated that they passed the ACR and the MQSA with no deficiencies, which is just a regulatory stuff. And then for their ladies' night, she said they were able to get 65 mammograms scheduled, which was a record for the hospital. So that was really good. And then the lab, Lanny just wanted to remind the providers that the GI panel and the respiratory panel isn't covered by commercial insurances or Medicare. So he just was asking the providers to be cognizant of that when ordering things because they can be over $1,000 that the patient might be stuck with. So just making sure that we don't end up leaving our patients with that. That was on what? GI panels or respiratory panels. You just can order what you want, like one specifically individual. So if you want testing flu, COVID, RSV, you have to order them separate. Like see if you just order that specific.
Order the specific pieces, not.
Right. And then Jim wants to look at bringing peritoneal and joint injection fluid testing in-house. So if they do like a joint aspiration, they can check it and see who's infection. He says that the machine can do it, but the staff just be trained how to do it. So he's gonna work on that so we can bring some more testing in-house. I'll let Shane talk about the nursing home. Home health, Heather discussed home health referrals and the diagnosis. Some of the providers were putting more symptom-like diagnoses, like weakness. And she said that to admit them from home health, she needs to have a more specific diagnosis of like what is causing the weakness, is whether like a hip fracture or Parkinson's or the underlying cause of the weakness in order to admit. So she just provided them with education. The acute care report at the time Donalda had 5 patients on the floor. 2 of them were skilled swings and 1 was intermediate. And then 2 of those were acute. Chart timeliness. Kathy discussed the changes that she's going to be making to the charting policy. It's not going to be any longer than 72 hours. The policy before said 15 days, so that definitely needs to be updated. Discharge changes. Epic made a change to how discharges happen, and it's just a simpler process for the providers. And also asked the providers if they still wanted to use LMAs, which is a type of intubation tube in the ER, and they decided they wanted to keep those in stock. And then just behavior meds. Donalda asked if any of the providers wanted to decrease behavioral type meds, so they just have a conversation with the person beforehand and just give them a heads up as to what's going to happen. So, other than that, that's all I got tonight. Awesome.
Good job. Go ahead and let Shane go.
Okay, November, we averaged just under 40 for our census. We had 2 admissions, 1 discharge in November. That was a little better than October with discharges. Yeah, we had 5 in October. So current census is 41. We are looking at 3 referrals beginning of the year. So, staffing, we currently have 4 CNA staff openings with agency. We have renegotiated the agency contract starting December 1. We don't want to pay overtime on any of that. So also been working to get the staffing hours more aligned to our current census. So that's been a good push to move back in line. So we have CNA class starting next week. We got 2 people in that, and then we also have 2 potential CNAs in the hiring process right now. So hopefully those agency hours keep going down. And then for the referral part of it, we're changing. We're trying to get away from the wait list, watch list, and just telling people that we have open beds. I think that's where we go, hey, we have this wait list, and we have open beds. You can immediately get to that. So then we've changed kind of our process from the hospital to the nursing home. We got somebody who's meeting with people there. And then we started discussing having swing beds come over for activities and meals, just so that, hey, this place isn't so bad, and hopefully they're not so scared to move into the nursing home. So looking at an open house, which will Wonderland in January. So, and then, Facebook posts and things like that to get out we have opens.
We're gonna advertise that.
Mm-hmm. Yeah, sure, yeah. Otherwise, we might want to have it because nobody would come. So. Done?
Mm-hmm.
Okay. So let's see, I'll try to run through the I've talked with the senior leadership team and the executive team a little bit about having, in the next year, having a Weston County Health Services Academy. So taking all of our employees through that and really working on customer service and service excellence and what that looks like, and going over our employee handbook and making sure that everybody understands that we all have the same expectations and things to follow. So that's one piece. I just thought of it over the last few days and introduced it to people. So it's just here right now. It's not anywhere else, but that's what it's gonna look like. On the 340B work that we're doing, we were trying to decide if we needed to get a compliance person to come in and do an evaluation for compliance to see where we were at. But we found out that Craneware is actually supposed to be doing that for us along with Monuments. So they sent us a report and we spent 30 minutes with them because that's all they had for us. We got another hour meeting between Travis, Suzanne and myself. Suzanne and myself we got some stuff that there's medications that they said we need to reverse potentially because they were at the Upton clinic. We found out we may have to have file under our same 340B child places so that we get qualified for the 340B in that. That hadn't been done before, but also some of the medications that they may say that we have to send dollars back to the manufacturers. We also have the ability from the compliance person to basically set that to zero. So we spend until we get to zero and then not have to send money back to the manufacturer. So what I'm really trying to say is we're trying to get our hands wrapped around the 340B program and know what it's doing. And there's people that are doing the work for us behind the scenes, but we need to understand it ourselves and then know how to really read our reports. I just got a notice from one of the vendors that they owe us money. And so I sent it to Suzanne and Travis to look at, but I think we're going to have another follow-up meeting, just the three of us, to talk about where we go from here as well. But we are trying to figure that program out and figure out what's gone on with it. And quite frankly, just some stuff that could have been done that wasn't done before. So, yeah. I sent out the community health needs assessment. I'm not going to go over it today in detail, just because I feel like that's something we do in a strategic sense over the first part of the year as we get ready for our next fiscal year. And that we did get a lot of comments, and I would say focusing on customer service is one piece that we can do from a making sure that people really feel like they're welcome when they come in. The second part of it that we saw is that people definitely want the ER, they want the nursing home, they want to be able to go to the clinics and things like that, but they want those things there and available, but they also want some extended hours if they could have them for the clinic. So I'm going to look at that. It's hard to staff clinics on the weekends. I'm just going to tell you the truth, because providers are the problem. That's the real truth of it. And the staff will go right along with them. So, I mean, they get in a journey together when that stuff's going on. So it's a process.
It brings unity.
Unity comes into the play. Yes, very much so. So it's a matter of talking strategically about that and looking at some of our rules that we may be able to utilize to our advantage, because there are rules about having expanded hours because we're a rural health clinic. So we'll see what comes from that. Tony Blake said that he does have January 20th through the 24th, if any of you guys can do that week in January for training, so that you don't have to wait till February, after February 14th. That was his only thing he could give me, is January 20th through the 24th. But at least it's January.
I could do that one.
Carrie.
All right, you guys can.
Oh, you can't either?
I can't. That's when I'm in out of town for a week.
So is the February?
It's after the 14th. After the 14th, yeah. I think the 14th is on a weekend.
It's a Friday.
Yeah, a Friday. We don't want that. Yeah. So, yeah, so if you guys can give me dates in February after that, that would be nice and challenging for you to do, but I could send that back to him and I'll try to really press him to make that one work.
So does anybody have dates in February that will not work?
Yes, but I'm looking for them right now. Sorry.
Otherwise, we're gonna have to come up with some other, I don't know, strategy, some plan, some plan.
Midnight to 4 a.m.
That's good for you guys, but it's terrible for me. I can't make that up.
After the
I'm sure
that
I'm
should be
busy.
effective at making us really do a bad job.
After the 19th, I could make it work.
I have no life.
Okay,
I have a lot of life, but it seems to be pretty flexible.
okay,
Yeah, I guess that's.
so the 19th is what day?
19th is a Wednesday.
So, okay, and Wednesdays are better days for you guys than Fridays are not good, or Wednesdays are bad days for somebody in here. I can't remember. And Wednesday's okay?
So is that the third week? Like, is that the week of all of our meetings?
That is, the meeting will be the 20th.
So the meeting.
Well, I guess you could do that if you want to. That'll just make my life fine. So, but we could do it if you guys can do it.
Do it on the 19th.
I don't have my plane ticket yet, so that's the day I was planning on coming back on the 19th.
Well, there's the 20th, which is Thursday, but then you guys would be meeting for training and then you'd end up having a board meeting, right?
What was it? Who was it that can't do Fridays? Someone.
Sure.
Nathan's,
You.
it's hard for him to do, yeah.
Okay, well, I'll just make the plane ticket for the 18th. How about that?
Okay.
How soon do you have to, when are you want to make your tickets? Like,
When am I gonna put them,
so like
set them
if
in stone?
Tony- Yeah, if Tony can't do it on the 19th, then there's no sense in you changing your ticket. Or the 18th, or whatever date.
The 19th, right, so yeah, so check the 19th date and then I'll find out. It's gonna depend a little, my mom's gonna get an even right in there too.
Maybe I can say the 19th or the 20th, because that's Thursday.
Yeah.
Ooh, but you then are, no, your meeting is gonna be the,
Yeah, you're talking.
yeah, about,
half day.
yeah, half a day, 4 hours or so. Mhm.
Yeah, I think
Okay,
if we have to do it on Thursday, so be it. Is that okay with you, Ted?
I think this is important, not pushing.
okay. Okay, then that feels almost hopeful. I'm very hopeful. So,
So I had to go check my calendar. I can do the 19th, but Shannon has a quality meeting at 4. So as long as it was before 4, or maybe, I mean, we could overlap it a little bit. But otherwise, I'm generally.
you can just run that meeting a little. They'll have a quality meeting though too.
It'll be at the quality meeting. It won't just.
Oh, yeah.
Right. So I guess if we do it on the 19th,
Whatever.
earlier in
It doesn't matter to me.
or did we already move past the
No,
Have to
we're
make-
still talking about
So it
either
would
the
be like
19th
the
or
first part of the day on the 19th? Are we thinking like? 8
Is the
to noon
20th
or-
Thursday? That is a Thursday, right?
Noon till,
Yeah.
noon to the board meeting.
Now you could do, you guys could do noon to whatever and then go into the board
Before
meeting.
and then
Yeah,
go
we
to the
could just
quality
do that.
meeting. and
Yeah.
then do before and go to the board meeting.
All right, let's try for the 20th
Or the 19th.
Or the 19th.
or the
Either one of
19th,
those
going
days.
once, going twice.
And looking at noon
Okay.
before with quality to follow on the Wednesday or board to follow on the Thursday. Yeah.
I'm proud of you guys. You got that done faster than
Well,
sometimes.
we'll see if it works.
Yeah.
Okay, so, Dr. Reimer and Jan's, retirement party was very successful. There was a lot of people there and Dr. Reimer and Jan's retirement party was very successful. There was a lot of people there and there was goodies and a lot of, I got to meet some new people too, to be able to see them. So I think those went very well. Dr. Reimer Some people say he left on the 18th was his last day, but he told me he was going to make sure he got everything out of there by the end of the month. So I still have to find that out tomorrow. I didn't have time to find
He
it out.
told me that he was in the clinic through the end of the month.
That's what he told me. So I just live here, you know, I don't know. So Jan, and then Jan wanted to stay on PRN in case we really needed her or something. I said I would do it for a year and see whether we see her or that works, because quite frankly, she wasn't all that predictable. So we'll see. We'll give her that year. And Dr. Reimer kept his credentials for 2 years just to kind of keep him, I don't know why, keep him thinking about it just a little bit.
Does that mean he kept his credentials?
Well, that means that he's still credentialed with the hospital and
So he
the
could
clinics
still
and
work
stuff, so he could still work. He's not going to be employed, but he could, but say he wanted to, I don't know what happened. So suddenly he wants to come see a patient, and I really don't know what would come up, but if something did, or say we got into a crisis and he thought he could help us out.
Right, that's what I was
But
thinking.
if
If we had,
like if one of his old time patients had to go into the nursing home, he could come and see them.
Right. That's exactly right. So it's just, I think it's really hard for doctors to let go.
well, it's hard for all of us.
Mhm.
It's hard for their patients to let go of them too.
Yeah.
It's
Mhm.
just
What was
difficult.
Jan wanting to do?
She just stayed PRN.
So
Stay PRN. She's having a hard time letting it go too, because when she got around to her patients the last couple of months, when we finally got her some dates, she really, had that heartfelt stuff with people. So that they're like, well, maybe I can work a little bit again, but
but they would have to get your permission.
they'd have to get my permission, and there'd have to be a hole. I wouldn't be just putting them in for
So
something.
Ted,
to
I
do.
think PRN means if we call you,
As needed.
you can work,
You can work if you
but
want.
there's no guaranteed shifts or anything like that.
Oh yeah, I forget about the initials. PRN. Sorry about that.
As needed.
As
As needed. That note stands as needed.
But
PRN.
it does. That's better than AS.
Maybe it's
Yeah.
So I
Gotta
did.
give me the root word.
Yeah.
I do have a meeting tomorrow, and I've talked to him a couple of times. There's some pain clinic doctors, and they do injections in that. And I think at first there were some providers not sure about that. The truth is there's a lot of people in the community that are sure they need pain management. So I think that it behooves us to talk about it and to really look at that from a realistic standpoint to see whether or not that's something we can offer the community. Our doctors have to be part of the ones that would do that, but I also think that there may be some way to look at that, because they could run their own little clinic time and then set people up for injections or something. That was another thing that was really brought up in that stuff, was the needing pain management. And we have one provider that's so resistant to pain management that it's almost, in my opinion, too far. And then, and then we have people that have had pain medications that have been given by doctors that have known them for 25 years, and we can't just ignore that. So it's a matter of trying to find a happy medium. So I'm going to talk with them just to see.
We're talking about cortisone in the shoulders,
Mhm.
back area, or
Yeah.
wherever.
Right. And they would do it with a C-arm. We don't have a C-arm. I finally convinced Keisha that we do not have to have a lead wall to do that. And she said, well, it'll be better. It's always going to be better with a lead wall, but it's not required. They don't do it in ORs, so they don't do it in procedure rooms. And so the C-arm allows it to be much more safe too for injection. So there's just people that are going to need it. A C-arm is like
It's a C arm.
it's like a half of a looking MRI machine, almost like if you were looking at an MRI. It's got a little half hole area that you use, and you just put it over the back of the joint or whatever one you're going to do,
Look well
so that they
there.
can see.
They can see where that is.
MRI machine.
Is that's what it is. It's
Mm-mm.
while you're doing
No.
it on an X-ray.
You can, but then,
Oh, so it's
Yeah, it's like
they'll use a C-arm a lot of
attachment,
times when they
Oh.
put a hip
to a
back
machine.
Right, they'll use it for.
or an elbow, and
So
then
how much would
they'll
a
C-arm it
C-arm
after to make sure.
Well,
it's in.
They're going to help me look at that, because I told them I don't have a C-arm and I don't have capital. So they said that they had some ideas for me, and they are also building a Performa. But they said, you guys build the Performa and show me what it is that you can do, that you think you can do out of here. So
They can bring one.
yeah, and the truth is, everybody that goes to, there's plenty of this people in this building that go get injections. So I think it's behooves us to at least look at it as one of the services that we have.
Really like them. Some people.
Yeah.
So we would have to have the CR to make this thing.
Well,
Is that
there are
right?
some injections they do not, like knee joint injections, they are not doing with a C-arm. You don't need that for those, but back, I think sometimes.
Back you really do, and shoulders are kind of tricky too.
So, I
Yes.
mean, but yeah, so some of it can be done without, but yeah, like you said, have them bring us a proposal and see what.
Yeah, see what
they
it
can
says.
offer.
And in that vein, I think I put this in my letter to you, but the Hoskinson's Clinic providers came to see us, and they have lots of specialists. We just talked to the ambulance service today in EMS, and so they were talking, well, if you guys would refer more people sometimes to Gillette, it'd probably be easier for us to get some of your ambulance pieces done better, which of course, this is just horse trading stuff they talk about. We send them where we need to send them. But I said, well, with you getting more specialists in Gillette, and potentially on what you guys are capable of doing, we can certainly let our doctors know that we have that capability in those, if we have work with those specialists. So in other words, whoever wants to bring the specialists here and get them going here is probably going to get a good chance at a referral base that they can then move the business where they want to move it to. And so
We have to pay the specialist to come.
we haven't gotten that far. Probably what would happen is, well, I don't know yet what will happen, but they would get paid better if we paid them a per diem fee, a daily fee, and then we billed for them. But a lot of them like to pay a rental, and then they bill themselves for their services that they do. So we wouldn't get anything except community services that people need, and then keeping our secondary things like labs in here and x-ray. And so it's more about building your outpatient volume, and physical therapy is another one.
And where would they work?
And we have a
Across
specialty
the
clinic.
street or
The clinic in
Yeah,
here.
the clinic here. Yeah, but there's neurologists, neurosurgeons, cardiologists,
So is that
geriatric.
is that sort of thing, is that gonna take? Is it gonna take from?
From what we
is it
know, we
gonna
refer.
drain on us at all?
Well, no, it shouldn't, because they're specialists. We don't have those specialists.
Right.
And
So for instance, like OBG and Peds,
Right.
most people have to go out of
We
the
have to go to
community
Spearfish
for
or-
OB and Peds. Where if we had specialists come here, then they stay here in the community, and like Kathy said, the
We get the
ultrasounds then
labs
come here, the labs, they come here, but it's a community service to make it so that our people don't have to go.
So
And
my
cardiology.
question is, typically it's the primary care provider who's at the center of the patient's needs and who interfaces with all the different specialists to make sure all the drugs work together and stuff. So would these specialists who come be working with our patient's primary care
Yes.
providers at our clinic?
that they met with the primary care providers that came over. You know how that is. I can't always get all of them over here, but they, John was here, Haverly, and Dr. Haverly, and he was very excited about it. They have all their cards and everything. They talked to him very detailed about what they do and how they provide services. And one of them was a doctor, what's his name? It's hard to say. Repaz, which we've had him here before, so we'd be able to get him back into the community again. And
So would the patient flow be such that our patients would see their primary care provider and then the primary care provider would schedule the appointment, and then after they come to the specialist, they go back to the primary care provider.
Right, exactly.
To continue the plan. 'Cause I
And
know a lot of-
Hoskinson's clinic says that they're promising that they'll have reports back to the doctors within that same day or the next day. So that would be another thing that would be good, because we don't always get that same amount of service from Monument too. There's a little bit of me making some competition feelings for Monument about stuff, because I think they're too comfortable. And
Provides patients.
and the lab they're building is going to be this huge lab. They said that they would undercut any prices that we are having to pay now for labs that we send out, so we could save some money on the lab side too, probably starting in the summertime when they open it, and they'd be able to do that. But So they're doing some price competition. And the other thing, whether it's how you feel about it, but some people like the idea when they were talking, because patients could go to a Wyoming facility. They could stay in state to get their care and not have to go out of state and worry about it as much. So,
And from the self-pay perspective, but of course it's hospice, so that's different from the Gillette hospital.
mhm.
Self-pay, Gillette's a wonderful place to go to.
Yeah. So, and the other thing that I would tell you is I found out that we weren't doing a sliding scale fee for people at the clinic, which is one of the biggest things you're supposed to do in a rural health clinic. Yeah, exactly. So we weren't doing that, and they said that they never have, and I'm guessing that that's true because Dr. Reimer, even though he sold it, still sort of was the master of the decision making over there. So, and I mean that very respectfully, but they weren't following policies like that. So we'll be fixing that now so that we do have a sliding scale fee and people aren't expected, if they don't have the income, to pay more than they can afford to do, which should help our clinic a lot. We are in competition with what I heard this week. Ashley is servicing people for however many visits they want to come for $110 a month for a family. So if she's doing that, that is real competition, because that's basically a private concierge medicine. And so people I don't know how that'll do for her workload, but if they get all the visits they want for $110, we can't have that kind of a service line, but we can compete on trying to get people in better and getting some services in and those kinds of things. But that is part of it.
I wonder how that will do here, because you have to have a very special market for people willing to pay that.
Mm-hmm. 110 every month, yeah.
110 every month, and you get all the visits you want.
Correct. But if you don't go at all, you still pay them. I mean, it died fast in the markets that I worked in, but in places like Arizona, big golf communities and stuff, it's like fabulous there, and they have specialists, everything in their network, but it's very special where it takes off, and I don't know if it will take off here, but
I know one of the doctors
interesting.
in Gillette was doing that, because one of the school teachers, that's how they elected to. It was so much a month.
Yeah.
And they could call her or go whenever they needed.
It's an interesting model, because if you get other doctors to merge into your network, then you can take care of all their needs and they don't need health insurance.
Mm-hmm.
But
it's an interesting market, and it does tell me that she's really interested in competing, but it also makes me wonder how their billing cycles are going, that they're changing that model too a little bit. So just saying, I think we need to know about it, not to be naive about it. One of the meetings, it was the Hoskinson Clinic, she said she had 8,000 patients. I know that's not true, because we don't even have that many people in the whole county, so that's probably not the case. But I think she might have meant some sort of volume that I don't know, but I don't even think 8,000 volume would play right. So I'm not saying she said wrong. I'm saying she probably missed the number or something. Yeah. So anyway, because she's a nice gal. She does, and I think they really focus on customer service. So we've got to really focus on that. Not that we shouldn't have anyway, but we really got to focus on customer service.
Competition makes everybody better.
yeah,
It's going to be
I
real
mean,
interesting in Rapid City now.
for this.
You all hear about the Rapid City?
Yeah. Huh?
Sanford. Yeah, Sanford finally got their foot in the door in Rapid.
I do not think they're going to put an ER in, but I've heard they might put in a surgery.
They bought Black Hills.
Oh, did they?
They did. They bought Black Hills Surgical Hospital.
Well, and
Sanford bought it.
And Sanford's known for working with small hospitals too. That's really kind of their reputation. So I would not be surprised if they don't start reaching out as well. So it's really, as long as we kind of focus on our community and we try to do really good service, hopefully we just get really good partnerships out of it.
Yeah.
In addition to the weekly printed version of the newsletter journal, we also promote our community and share important information on our award-winning website, newslj.com, and in our weekly email newsletter, Nuke Now. We also connect with readers through various social media platforms and invite you to check us out on Facebook, Twitter, and Instagram. You can even take a look at a recent meeting of the City Council, School Board, or County Commission on our YouTube channel. We do hope that you will go to newslj.com and subscribe today, and we look forward to making all of our great content available to you. But regardless of your level of support, we thank you from the bottom of our hearts for doing your part to preserve a free and independent local press.
As long as we kind of focus on our community and we try to do really good service, hopefully we just get really good partnerships out of it.
Yeah,
It'll
be interesting over
and drive costs down, but I don't know. So, and then the only other thing is that we aren't using a quality service. Like there's this thing called Interqual, which is a quality coding kind of thing, that if you look at somebody and they have pneumonia, it'll say these are the symptoms they should have, this is the diagnosis, they should stay this number of days depending on what's going on with them, and if they have other complications then it adds different days. And what's important about that is that it helps providers decide things like how long a person can be in the hospital. Our staff probably are really stuck on the 48-hour thing, and really it's an average of 48 hours. So we're under one whole person in our calculations for our inpatient stays, but we could have people stay 5 and 7 days as long as we stay under that 96 hours. That's the mandate. So we need to have a tool to help doctors make those decisions as well as the staff, so that they can maybe think about, well, it's okay if this person stays here with pneumonia or CHF. I saw a couple patients I wondered about why they went out with COPD or CHF. We should be able to treat that in here at this facility at our level, unless it's a complicated one, with 3 or 4 days. So we need to really rethink that with our providers on how they're looking at the 96-hour, 48 hours and stuff that they worry about.
And so is that something you're looking at, that tool, or?
Well, I actually asked Donalda to look at it because her team's going to be the ones doing it, but there's a couple of different ones that are acceptable by CMS, but Interqual in particular is CMS certified type of. If you use it, you will be following Medicare guidelines. If you follow Medicare guidelines, you're following payer guidelines for the most part. So, yeah, that was another thing that Tish said, you guys don't use it or call here. We're like, no, we don't do that. So, nope, we do not. And it was not on the radar with all the other things for a little while. So that's it. That's my report.
I have one question.
Sure.
Did we only look at the treasurer's office?
You mean to get the?
I did call, and we do pick them up every month.
Uh-huh.
Jan does them, so we're current.
Oh, good.
I thought we'd have a nest egg.
Yes, that's right.
We were current, so.
And where is it? Is it on this report, your cash report somewhere?
It is included in the cash report, so I think what I'll do is break it out because it doesn't get broken out.
Is it under IGT?
No, they put it in with operations. So I think what I'd like to do is, instead of having the IGT and other, just break them out so they're on separate lines so they're easily identifiable.
Yeah, it's easy for me to, I know what we got brought in, but won't you know which one it is probably, but well, it isn't for the treasurer part because I don't know what the treasurers are giving us. What are they giving us roughly for tax?
It was 260,000.
It'll vary.
Mm-hmm.
So it varies, but
by
last time it was 260,000, but it's still be really nice to know. I'm like, could you let me know? And I need a copy of that for the auditor, so. It's a work in progress.
Communication.
Put it.
Yeah.
Yeah, not knowing is, and that's,
Okay,
Is there anything else? Any other comments, questions for Kathy?
I want to put up make sure I have the right one up. So just 1 second while
I just have one comment, and it actually was from Kim's report. When Kim reported that radiology had scheduled 65 mammograms during ladies' night, that is just like a testament to what we were just talking about telling the community a service that we have and then filling a need. I mean, that's a success story. That's really awesome. Could you make sure Keisha
Oh,
knows
sure.
that's really awesome?
Yeah, absolutely. I'll let her know. She
was ecstatic that
she's
night, for sure.
feeling pretty
Yeah, but
ecstatic
ladies'
about
night,
it.
I mean, she put a lot of work into ladies'
did.
night, and it was obviously a great thing for the
It was.
hospital
There was
and the
a lot of
community.
people
So
there. Yep, that was good.
More things like that would be
right.
I know. That's why we have an executive session
Yeah.
in part.
And Winter Wonderland coming up.
Yeah, which is a great idea too.
I'm trying to make sure which one of these is the right one. Allison?
Don't schedule snow. We can do without the snow.
Yeah, exactly.
Let the staff know.
Allison?
Yeah, I'm here.
If I stop sharing and you share the screen, will you put the right agenda up with the right language on there? Because I'm getting confused by them.
It's the one without the Zoom link.
Okay. One without the Zoom link.
And it says legal issues instead of trade secrets
Legal. I wondered about the trade secrets.
or legal advice.
It's the one. It's not the one you just sent, right? Or it is the one you just sent? Let me look.
There it is.
Legal advice. There we go.
Yep, that's it.
Okay. I want to make sure that the language is up there for you.
Okay, so are we ready to move into the executive session now?
Does anybody need a break?
It sounds like at least one person does.
Yeah.
No, I find it difficult to understand why we'd go into legal session or legal
Executive session.
executive session and then take a break.
Right.
Yeah, right.
Because it gives me and everybody else a chance to mingle with the public and quote unquote, we're in executive session.
Yeah, you're right.
You guys want a break then?
So,
Yeah, let's take a little
so,
break.
so we'll take a break and then go move into executive session.
That would be,
The bad
That
thing,
would
the
be the
bad
more
thing about
proper
it
way.
is it makes people sit here for that much longer that are just.
well, I know,
And they're-
I know we've had the paper complain about that, but this is our meeting, not the paper committee.
Absolutely.
Yeah.
So is Kim gone? We just need to look through.
We need to look through those and then just sign them.
And I sign.
And then I'll give them back to her. I'll give them back to her. Yeah, she doesn't have to do anything.
Yeah, my little eyeball popped out of my head.
There you go. You got her.
What are we racing our hearts over?
Cookies.
Oh.
Oh, it's awful. You know what? It wasn't as bad as I thought.
Good.
I
Good.
had myself so psyched up.
Well, that's
And I
good.
kept watching YouTube videos and I
Mhm.
finally.
That's always the dangerous thing to do. Is watch all those YouTube
Especially when
videos.
you hear them hammering that.
Right, right. I know that hammering does sound awful.
That's, it's got a Christmassy taste to it. I don't know if that's a good way to term it or not.
It's a good term.
Christmassy flavor. Madam Secretary, I don't see you anymore.
I know.
You know, library.
I'm doing good.
Good to see you.
See you guys. How's Thanksgiving?
Good. I'll be glad when it's January 2nd.
The staff were really happy to get a turkey or a ham. It really made a big day for them. Those things, they cost a little bit, but they go so long way for making the environment better. It's really important.
When I worked in
Mhm.
Casper, the cardiologist gave everybody that worked with them ham.
Mhm.
And it was always nice to get,
Yeah.
know that you're gonna get a ham.
Yep, Deckers sent us a card and said, thanks for shopping local, you know, and so that always helps too.
Josh was a lot calmer than Dylan. I'm not sure Dylan was that still.
Yeah, Cameron was
And
a
then
little
our,
bit of
now
a
our
loose cannon, but
gift
Cameron,
certificate we give every year for Christmas, is $50 for groceries. And it's at Woody's, so we did Deckers and then we joined Woody's. So we're kind of trying to even it out.
So I would do my hours during the week. And then on the weekends, I would bring my baby son and put him in the package plate in front of my door. And it was in the nursing home, the residential. And they could have leave to come down to get Joshua away.
I'm so sorry about the first of the meeting.
Circles around. Push a wheelchair. It would have been awesome.
Well, I'm sorry about the first part of the meeting. I don't know what happened that it disconnected the admin thing and like, well, I thought I had it handled. So,
The problem is
I'd get fired probably as an executive. I'd probably.
We didn't hire you as an executive.
You're a little slow. We're gonna have to do something with you. So.
We did, we promoted you.
Yeah.
Not all the time, but
That's pretty funny, yeah.
But it seems like I'm self-hungry. Maybe that's why I got high blood pressure.
I think people don't realize, especially if you're working outdoors, I don't think they realize how much salt you need.
Mm.
Our family eats so much more salt than most people, and it's not, and everybody's healthy. It's not, it's just that we're
Yeah, you
outdoors
need
and
it,
we're
yeah.
sweating.
Mhm.
I'm sure you crave it more too.
We do.
I can remember my dad coming in, working outside in summer. And he'd sit down and have a beer, and he didn't drink a lot, but he'd always put a ton of salt in it.
Exactly.
Really?
That sounds good.
I salt, or I used to salt my beer. I love green olives in beer because they are salty.
Tommy's pickles.
Really?
Pickles all the time, not in his beer, but.
Now that would be
Salt
interesting.
beer, or pickles in beer,
I had some pickled beer here. Would you like some?
Huh? I'm not necessarily, I like olives and you can put celery, but no, now the tomato juice, I drink tomato juice every day with my lunch. I gotta take a can of tomato juice.
Okay, so are we ready to?
Yeah, we can close. JT, will you close the doors for me?
Oh, we actually we have to leave them open until, while we
Yes,
make a
we have to
motion.
open it.
Oh,
So are we still recording?
Yeah.
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 So we need
We
to.
need some recording.
All right, I'll do it unless somebody else really wants to.
Go ahead.
All right, I move we enter into executive session under 16 hold on.
That's gotta come back.
I didn't do
Over
that,
to
did
the
I?
W, over to the W.
What did I tell you I did wrong over here?
164405A.
Nope, that's not, that's not
We
it.
have, we have updated link.
We have the updated one.
Oh, everything. but
It's
true.
right here.
I'm
Okay.
just gonna start again. I move we enter into executive session under 16-4-405A2 to consider the appointment, employment, right to practice or dismissal of a public officer, professional person, or employee, or to hear complaints or charges brought against an employee, professional person or officer, to consider acceptance of donations which the donor has requested to be kept confidential, and to consider or receive any information classified as confidential by law, including legal advice.
I second the motion. All those in favor say aye.
Aye.
All those opposed, the same. Okay, we will move into executive session.
Wendy? Let me get back to the Zoom meeting somehow. Wendy?
Trying not to listen. She's probably in her living room.
Oh, Wendy. I'll call her.
So are we sure we're not recording?
Well, she's asking Wendy to stop recording now.
I was worried about that too.
We do not need a hot mic.
Hey, can
No.
you stop the recording now and then I'll let you know when you can put it back on? Thank you.
It should announce it to us.
It should be down on the bottom there. I just don't even have the choice or I would do it.
Tell her it'll be about 2 a.m. We'll get back to her.
Todd.
The new store. This is the one-stop shop. We have a pharmacy. We have a bootlegger's liquor. The deli, the food that you can get at a lunchtime is so amazing. The coffee shop. Certain Friday mornings, there's 30 people sitting here in all these chairs. This is the hub for people to come and visit, have their coffee, have their donuts. It's amazing what this area has done. Totally amazing.
So we are back in regular session at 10:26.
Actually, I think it.
All right. Madam Chair, may I make a motion? I vote to restructure the materials department to a manager and 1 clerk and approve the associated budget adjustments for salary and benefits.
Your second.
I will second that.
All those in favor say aye.
Aye.
All those opposed, the same. So we voted to restructure the materials. The motion passed.
Madam Chair, may I make a motion? I vote to restructure the clinic to add the clinic manager position and salary and benefit costs to current budget.
Have a second.
I'll second it.
All those in favor say aye.
Aye.
All those, wait, I should be asking for discussion.
You should be, but
Okay. All those opposed say the same. So the motion to restructure the clinic, or to restructure to add a clinic manager passed.
Madam Chair, may I make a motion? I motion to accept donation from an anonymous donor and to spend the funds within the guidelines of our 501c3 status and earmark for the donor's wishes to be spent at the donor's direction.
So, it's been moved and seconded. Do we have any discussion? Okay, all those in favor say aye.
Aye.
All those opposed, the same. So that motion passed as well.
By the way, Kareem, I just naturally look all the way at the end of the table. I do.
Madam Chair, I make a motion that we stay for 3 more hours.
Oh.
I won't even ask for a second. Then we see you in the new year, huh?
And then we have a motion to adjourn. Oh, whoa, 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 whoa. We haven't passed these. around.
Oh, yeah, that's right.
Yes.
You need to approve those, yeah.
And
There's
in
no,
executive.
huh?
In executive.
Well, just
No, we have to make a motion in regular
yeah,
session.
to do it, yeah, and their records are clean, so they've been through the providers and quality stuff.
You have their names?
Yeah, so
Patrick,
Madam
what is
Chair, I make a motion that we approve, can I just say credentialing? We approve credentialing for Kimberly Goebel, MD pathologist, Heather Peck, MD pathologist, and Patrick Gleason, nurse practitioner.
Gleason,
Gleason.
Gleason.
ESO. He works in our ER.
Patrick, and what was X first name?
Sarah Noble.
No, I got
Heather.
I got Kimberly.
Peck's first name.
Heather Peck.
Heather.
And you got Kimberly Goebel.
Gobel.
Goble.
And Peck is Peck.
Yep.
Madam Chair, I second that motion.
Just gonna wait just a minute here.
Sure.
So I'll type up what I,
Way of time.
as far as financial.
I'm sorry.
Can I just say,
Report, you could just say, see attached report, because it'll be in the
and
folder.
you'll have the
Mhm.
report.
Yeah.
So I'll try to get these.
Did you all vote on that last motion?
Are we,
Yeah, that
people
sounds
ready
good.
to vote?
Sounds great.
Okay, all those in favor say aye.
Aye.
All those opposed, same. Okay, so now we can have a motion to adjourn.
I move that we adjourn.
Do we have a second? Any discussion? Good. So
Yeah, we can
all
stop the
those in favor
record.
Say aye.
Thank you, Allison. Merry Christmas. Happy New Year.
Yeah, thank you all. Merry Christmas to you.